So good evening. Good evening. This is Dr. Tonui. I call in from Eldoret, and I will moderate this session this evening. So it's an opportunity to say thank you to KNH and University of Nairobi for their series of webinars. And this evening we are talking about a topic that is so dear to my heart. We want to talk about frontiers in cervical cancer elimination. And we have 3 speakers, and we will do this teaching in 3 sessions. So our first speaker will be Professor Nelly Mugo, who will talk to us about innovation in the process of cervical cancer elimination. And then we will have our colleague, Dr. Anis Amburu, who will talk about self-care, and Dr. Doris Ndenya, who will talk to us about new technologies. So I would like to start us off by welcoming Professor Nelly Mugo. Professor Nelly Mugo holds a bachelor's degree in Bachelor of Medicine and Bachelor of Surgery. She has a degree in Master of Medicine in Obstetrics and Gynecology, and she has a Master of Public Health. Currently, she is a Senior Principal Clinical Research Scientist at the Kenya Medical Research Institute. She is a reproductive health specialist, and she has had 3 decades of work experience. Her research focuses on HIV and cervical cancer, among other reproductive health research work that she does. Professor Nelly Mugo has been an investigator in 2 landmark clinical trials. The first one was Partners PrEP study. This was a study that contributed to the evidence of that informed the change of the indication of Truvada for the pre-exposure prophylaxis for HIV prevention. And she's protocol lead in an ongoing study that is titled Kenya Single Dose HPV Vaccine Efficacy Study. They call it KNH-UoN. And this study has provided evidence on the efficacy of single-dose HPV vaccination. The study is currently ongoing. She's a member of International Papilloma Virus Group, and she's in the education committee for that society. She's also a member of Kenya Obstetrical and Gynecological Society. She has contributed and has been a member to several WHO and Kenya's Ministry of Health technical working groups and scientific committees. She is widely published. She has published over 180 publications in peer-reviewed journals. So I want to take this opportunity to welcome Professor Nelly Mugo to talk to us about HPV vaccination. Is there efficacy of single dose?
Okay, good evening, everybody. Thank you very much to Cox and KNH. KNH is my home institution. When I talk to Dr. Kennedy, I say, when I get to KNH, I really feel at home. It's where I trained, it's where I taught. It's the institution that built me. So thank you very much. There's so much to talk about HPV vaccination and the issues of elimination of cervical cancer. So the presentation I'm going to discuss today is issues of access to vaccine as we think about our goals towards HPV vaccination. And I think I need to track myself so that I don't take too long. I have funding from Merck, but this is investigator study and no conflict of interest. So we'll look at the global epidemiology of cervical cancer and HPV burden, which most of you know very well, and look at data asking the question, is elimination feasible in low middle income countries? And look at where we fall short. And then we'll look at some of the single dose study trials and the results and what that shows. Globally, we know the burden of cervical cancer is very high. It's the 4th most common cause of cancer deaths and incidence in women. But in 42 low middle income countries, it causes 90%. 42 low middle income countries carry the burden of 90% of cervical cancer deaths. And we know why this happens. We'll get into it soon. When we look at incidence, we know that 5% of all cancers can be attributed to HPV infection. That's overall, but amongst women, it's 8.6% of all cancers. And we know that is the burden of cervical cancer. Cervical cancer accounts for 83% of HPV attributable cancers, 2/3 of which occur in our countries. Now, if you look at the areas which are red, you notice most of them are in Africa, some in South America, and around East Africa and South Africa is where we have the highest burden of disease. I think in this slide, I didn't show it, but there's also a concurrence between HIV and HPV. And the countries with the highest burden of HIV infection have the highest burden of HPV infections because they're twin viruses which have synergy. The HPV infection has been shown to increase HIV infection, and HIV infected individuals have a higher burden of high-risk HPV types. We've already discussed about the burden of high-risk cancers, and you can see at the bottom, genital warts are the most common, cervical cancer, anal, oropharyngeal, vulval, penile are very few. And I've always said that if cervical cancer was penile cancer, I think we'd be handling this disease a little bit differently. So if we look at the distribution of HPV prevalence and the ages, you can see in Africa, we have over 22-24% burden of disease. And the peak age of HPV infection is around the age of 25 years. And as you go to other countries like Asia, their peak age, their prevalence levels are lower than others. But also to note that the peak age of HPV is when women are younger. And this is important for screening. And you note that, like for our guidelines, our screening starts from the age of 25, especially if you're using HPV, because when people initially become sexually active, there's very high incidence of HPV infection. In fact, they say up to 80% will get it within 3 years, but then a lot of it cleans out. And the challenge we have for cancer is persistent high-risk infection. So we can look at the disparities, geographical disparities of disease burden. And you can see that Eswatini has the highest burden, and Kenya, it's not a place of pride. We're still amongst 1, 2, 3, 4, 5, 6, 7, top 7 countries with the highest burden of disease. And as you move to the west, there's lower burden. But I want to say it's not because the women are any different. I don't think I gave this chart, but there's data showing in the 80s, Western European countries, especially England, had the same burden of cervical cancer that we have. And the difference that they had is when they instituted screening programs, not individual opportunistic screening, but a national program that achieves coverage. And that's where we haven't done well. I think I've already spoken to this, about the concurrency of HIV incidence and HPV, about high prevalence, persistence, and progression of HPV infections and persistence in presence of HIV infection. So what about the evidence that we have on vaccines? We have indisputable evidence on efficacy of vaccines. So all these trials I've listed here, it's called FUTURES-2, which was quadrivalent vaccine. Patricia was the bivalent vaccine early trial. Then we had one called CVT in Costa Rica, and then later on, the nanovalent vaccine trials. And you can see the vaccine efficacy rates were 98%. Patricia was almost 100% for any HPV infection. So all of them really high. And I want to tell you, if you Google measles vaccine and other traditional vaccines, the efficacy rates are not this high. Now, what's really good is that we have follow-up data for more than a decade. And I'll show you later for some of this work, we're looking to 15 years data showing persistent protection with these vaccines. Now, the early trials evaluated 3 doses, which is 0, 2 months, and 6 months for the quadrivalent, and 0, 1, and 6 months for the bivalent. And I'll come to discuss the issues of change in those schedules that has been seen. We've also seen population-level vaccine impact in reducing intraepithelial lesions and infection. Now, we know cancers take much longer to actually show. There's this analysis that was done by Suzanne Gallard. You know, Australia was one of the earliest countries to implement a vaccine program, national vaccine program. They started with girls around the age of 13, then they did a catch up to the age of 26, and then they did gender neutral vaccination and have had amazing results and achieved what they call near elimination. So they've had a reduction of warts by 90%, of low-grade lesions by 45%, and CIN lesions by 72% on a global level, evaluating people coming to their clinics. So what's needed is we continuously ask for extended follow-up and long-term output. How long will this protection last? And we'd like to see more data from Asia and Africa and really understand the issues of gender neutral. And ultimately, we will begin to see a long-term efficacy as the duration of vaccine use extends. So cervical cancer is one of the few cancers that we know what causes it. We have the high-risk HPV infection, so we know the cause. We have tools for screening early precancer lesions. We have effective tools to treat precancer lesions, highly effective vaccine, and I'll show you the data on the efficacy of single dose. And we know that early cancer, you know, stage 1 disease is curable with a simple hysterectomy and with very high survival rates. So what is our challenge? Our challenge is effective implementation of what science has been shown to work effectively. Now, WHO has made a call for elimination. And actually in 2022, they said it was a landmark year for cervical cancer. And I'll show you why. I'll not read through that. So the current elimination strategy goals for WHO stated is that they would like to see 90% of girls by the age of 15 vaccinated, 70% of age-eligible women screened with a high-performance test, and 90% of women who screen positive accessing treatment. But we've fallen short. We've really fallen short. So this evaluation showed that globally, if you look at this, only 15% of age target girls were fully vaccinated. And you can see the green areas where there's high vaccination rates in Europe, 75%, 77, 85 in the US, are also the areas who already had low disease rates from effective programs. Now you come to our areas and you see very low uptake of vaccines. So we talk about the inequity in access to both screening and vaccination. I'll show you some data for Kenya. If you can recall, the target for screening was 70% for elimination. And Kenyan data shows that only 16% of age-eligible women are screened. And you can ask the women around you, you find most of them have not been screened against a target of 70. And even more abysmal is that only 30% of screen-positive women access treatment against a WHO elimination target of 90%. So we've fallen short. Now, there's some very fancy modeling work that has been done that really demonstrates that elimination is feasible, which was my primary question. And it shows that if we vaccinate girls only ages 10 to 14 with 90% coverage, it would take us about 100 years to reach this incidence of less than 4 cases per 100,000, which is known as the elimination goal. But if you add once in a lifetime screen, we can reduce that by 11 to 31 years in up to 96% countries. And if you do this in twice a lifetime screening, we can also reduce this further we can reduce cervical cancer cases by half by 2048, averting 74 million deaths. So you begin to wonder, why are we not able to do this? It's interesting to note that the impact of vaccination and screening strategies is different by the current level of current burden of disease. So I don't know, these charts can be complicated. The one on the top is India, and I want you to look at Uganda. And you can see that, that with 50% reduction in India, they start going towards elimination of 3. But this in Uganda does not achieve the same. And this is in 27 countries, including Kenya, where we have very high disease burden and high rates of HIV. So we need to vaccinate and we need to screen to really show impact. Australia is a case study of success, but one of the first countries to initiate screening programs. In 1991, they had 70% coverage for screening and had reduced their disease burden by 50%. As soon as the vaccine was proven effective, they launched their national program in 2007. And in 2017, they added HPV screening to their program. And they estimate that they'll reach near elimination, but they're actually pretty close to elimination, even as we speak. They rarely see warts. Now, you know, whenever we tell these tales, we begin to worry. A success story is only for the West. Can we in Africa achieve the same? So I'm very fond of showing the Rwanda data. Rwanda was one of the earliest countries. They had a First Lady initiative that took up vaccination. It was one of the very first to have nationwide HPV vaccine, and they picked up an age cohort that vaccinated schoolgirls at the age of 12 years. It was school-based, and they achieved up to 95% coverage. So this dotted line is showing that they started with older, a little older girls, and they've been able, after they've covered, after these girls have grown older, now they can just target this age group of 12. And the other fixed line shows the level of coverage has continuously gone up to 95% for their country. So what's the impact? The dark bars show you the baseline data at the time they started a vaccination program in 2013. And in 2017, it shows you the amount of HPV at a population level in Rwanda. And they used urine samples. It was not invasive. And they've seen a reduction of up to 78% vaccine-specific HPV types, and alpha-9, which are related to vaccine types, up to 58%. It'll be very interesting to see what this does to cervical cancer burden in Rwanda. But it's a reminder that this is feasible in Africa. I think I already said that less than a third of the world's population of age-eligible girls have access to the vaccine. Mean coverage for dose 1 is 57%, dose 2 is 45%. So people are having difficulty doing and completing 2 doses. Now, as Kenyans, I want you to look at this map. Rwanda's achieved 94% coverage, and I want us to see the other country I have great, Zimbabwe, 91% for their dose 1, 67%. And you know, they haven't been getting money from anybody. But look at Kenya, we're at 33, and last dose 16. We're not doing well. And I've heard that we're having expired vaccines in our clinics. So we definitely need to do better. So what's the problem? We have a lot of vaccine hesitancy. A lot of misinformation has been spread, some by health providers, unfortunately, creating concerns in parents and influencing whatever. And we really misuse social media. Social media is powerful. It can be positive and it can be negative. But you know, vaccines have had the negative effect. So now I'm going to move on, and I'm going to look at the time and tell me if, yep, I'm over my time. I'm sorry. I'll be over quickly. Forgive me for that. So very quickly, we'll look at the evidence of single-dose HPV vaccination. And they started with evidence from observational studies. There's a huge trial in India where they vaccinated up to 40,000 girls A girl fainted, got stopped early, were able to follow up 4,000 girls who only got one dose. Costa Rica trial, which was one of the earliest CBT trials, also managed to have some people who only had one dose. So these trials have given us over 10 years of data of what happened amongst those who received one dose. The Doris trial was done in India, in Tanzania, targeted 9-year-olds, and KNH-U is our study that's done by myself, Professor Bukusi, Marisiana Onono, and Betty Njoroge, and it's called KNH-U. And we looked at effectiveness and vaccinated girls ages 15 to 20 years with one dose, and I'll talk to you about it. So there have been plenty of single dose trials across the world. You can see they're spread across continents, and Africa is well represented. So why is this important? We need high coverage of vaccine to really move towards elimination goals. We've seen data from observational studies showing that a single dose can work. And we need to think about vaccinating more than just that cohort of 9 to 15 and do what we call a multi-age cohort like they did in Australia. So for KNH-U, that's why we chose to vaccinate up to the age of 20. A single dose is easier logistically and cheaper and will reduce costs of vaccination. So our study, KNH-U, compared Cervical, which is the bivalent vaccine, to the nanovalent vaccine, and we used a meningococcal vaccine for delayed vaccination for comparison. And we looked for persistent infection. And we were able to demonstrate 97% effective protection with one dose in this age group. I think that we were very, very excited about this. I hope you also feel excited. And for Gardasil, the nanovalent, that was 90%, very comparative. These results are comparative to the 3-dose trials and the 2-dose studies. Our current guidelines used to be 2 doses for that age below 15, and I'll show you what WHO is saying now. The India CVT, the study, was observational, and they were also showing similar profiles of protection. See if we have this. So we're able to show that adolescent and young girls were protected for 18 months. The protection level was in keeping with licensed studies. And amongst the girls who had meningococcal vaccine, they had very high incidence of high-risk HPV infection. And we had very clear outcome goals. So we're very, very confident of our results. And we are continuing following up that cohort for longer durations. Now, this is the study which we called observational. It wasn't primarily set up to evaluate single dose. But when they followed up the people who, for whatever reason, ended up with one dose and compared with 3 doses, you can see that the antibody levels reach steady state, both for 1 dose and 3 dose. And though the antibodies for 1 dose are lower, what we've seen is that the protection, as you saw earlier on, this is CBT, stayed very high. And I want you to look at that. So in spite of it having a lower threshold, and we say we still don't know the cutoff threshold for protection, but it's higher than natural immunity. These studies have been able to follow different doses for the pre-cancer lesions, and the red dots were single dose, and you can see they favor vaccination and protection with 1 dose. So some of the questions is, what is the level of protection with single dose? It's been very high across studies. Is it similar to multi-dose regimens? The answer is yes. What about durability? The Indian CVT trials have over a decade of follow-up. What about age? In KNH-U, we vaccinated girls up to the age of 20. We have a lot of geographic diversity across continents. What we don't have is data amongst males and immune-compromised individuals. But there's lots of ongoing trials. I'll not go through this. So we're anticipating much, much more data. This HOPE trial, if you Google it, is in South Africa. They're doing surveillance, and some of the girls will not be vaccinated. Some will have 1 dose, some 2 dose, just the routine program outcome. So this is just to show you the amount of work going on. There's also work going on for 2 doses in Eswatini amongst HIV-infected individuals. So what's our takeaway messages? That single-dose vaccination will lead to substantial reduction in cervical cancer and is of high value as a public health intervention. Actually, Margaret Stanley, who's renowned as an immunologist and got the Nobel Prize Award, says that they simply made an excellent vaccine. And it institutes the sort of a protection it institutes is almost like the natural vaccines, natural infection, because it's virus-like particle in the vaccine. As soon as it gets, an antigen comes in, the antibodies just rise up again. So it does really, really well. Sorry. So the routine practice has been 2 doses without multi-age. It's less efficient. And we greatly propose for single dose. And the first people to adopt it were in the UK, and the WHO Advisory Committee also recommends updating dose schedules for 1 or 2 doses for ages 9 to 14, 1 or 2 doses for young women ages 15 to 20, 2 doses with a 6-month interval for women older than 21 years. So you can take this, that's the WHO recommendation. So this is Anita from Gates. Cervical cancer is a terrible disease. It causes unnecessary suffering. We agree with this. And it's unacceptable that anyone should die from a preventable cancer simply because of where they live, which is where most of our women live. And we can avert this. We have the tools, we have the knowledge. We just need to go out there and do what needs to be done. We need action and investment. And the world will need to determine if women's lives are worth saving. So thank you. And I really apologize for taking longer. But this is a story of iniquity, lack of access to screening, and treatment has spanned to lack of access to vaccine. Thank you very much.
Thank you. Thank you very much, Professor Neil Mugo, for an excellent presentation. I would like to ask the attendees to send their question on the chat box, or at the end of our discussion, we'll have a question and answer session. Our second presentation will be done by Dr. Anisa Mburu. Dr. Anisa Mburu has a Bachelor of Medicine, Bachelor of Surgery degree from University of Nairobi. She has a Master of Medicine in Reproductive Health, Moi University. She has an MBA from University of Nicosia in Cyprus. And she has a clinical fellowship in gynecologic oncology from Moi University. She is a gynecologic oncologist who practices in Aga Khan Hospital in Mombasa. Her clinical research are in the area of HPV-associated cancers, especially cervical cancer. She has also interest in pediatric gynecological cancers. She is a fellow and a junior faculty mentor for the International Gynecologic Cancer Society and International Cancer Institute. She is also editorial fellow of International Journal of Gynecologic Cancer. She serves as an expert advisor for the WHO Subcommittee on Cervical Cancer Elimination Strategy through surgical capacity building. She is a member of RGCS Education Committee for the development of palliative care curricula. Welcome, Dr. Anisa Mburu. She will talk to us about self-sampling. Can we do cervical cancer screening using self-collected samples?
Thank you so much, Dr. Sonoy, for the introduction, and thank you to KNH and COGS for allowing me to speak to you about this very important topic. I must say I was completely blown away by Professor Mugo's presentation, and I would love to hear more. So as you've heard, I'm going to talk about HPV self-testing. And as we know, primary HPV testing is a recommended screening test for cervical cancer. And this is because it has the highest sensitivity and specificity when it's compared to other screening methods such as the pap smear and visual inspection with acetic acid. In one study, the sensitivity of the HPV testing was up about 95%, while that of pap smears was only 55%. In another one, the comparative analysis was 96% for HPV and 40% for pap. And so that's why it's really recommended that for our women, if you want to screen them for cervical cancer, HPV testing is the way to go. And the way we collect the sample is through a swab of the upper vagina and the cervix. According to the WHO recommendations, for the general population of women, we start screening them, as Professor Mugo has said, between the age of 25 to 30 years, and we initiate regular testing every 5 to 10 years, depending on a negative test. But for those women who are living with HIV, the screening age can go even lower, up to 21, and they need regular screening of about every 3 years. And so you have to advise these women accordingly and make sure that they get the testing that they require. In terms of the specimens that we collect through this, for this testing, for the HPV testing, most of the time for most practitioners, they'll use a cervical spatula or a cervical brush. When it comes to, once the sample has been collected, we place it into a transport medium or a buffer and it's sent out to the lab. Patients can use the same collection media that we use as practitioners. For example, the Cyto brush, a regular tampon, a day crown or cotton swab, and even cervicovaginal lavage. So I'll go through some of these collection devices so that whichever you have in your setup, you can be able to know how to use them and how to advise the women to use them accordingly. The commonest brush that we have, especially that started off the self-collection sample, is the Evelyn brush from Rovers. And it is a very nice setup that is quite easy to use. Once the woman gets it, you just advise them to take off the cap. And usually the brush is sheathed, and they insert this part of the brush into the vagina up to the wings of the Evelyn brush. Once they have inserted up to the level of the wings, then they use the plunger to push in the brush so that it's released from its sheath. Once they've done that, now they turn the plunger 360 degrees clockwise or anti-clockwise 5 times to the sound of a click that will be heard with the brush. And this way, once they're done, they just remove the brush, pull back the plunger, and the brush will be sheathed again. And they always have to avoid touching the brush. They refill it and return it to the packaging and send it to the lab. And so other setups have included the cervical spatula, this being one of them that has been launched particularly in Australia, where the woman inserts this end. I hope you can see my cursor, but they can insert this end about 5 centimeters into the vagina, turn the spatula about 360 degrees 5 times, and collect the sample. I have a short video showing the Viber brush, which is somehow similar to the spatula, that you can see. It's a video that is used to advise women how to do the self-collection with the brush. So I'll just play it. It's only about 30 seconds. So as you can see with this Viber brush and also with the spatula, most of these tests, you can fill them up and send them to the lab. Another one that we have in the market is a Q-bin tip. As you can see, it's a very thin, very blunt kind of collection device, and it has some baskets at the very end. And this way it is used to, you do the same procedure as you've seen with the Viber brush and the spatula. Insert into the vagina, rotate it 360 degrees about 5 times, and seal off the sample and take it off to the lab. Cervical vaginal lavage is one of the other methods that have been used. Again, this one is very simple to use, very easy, and it's always important to explain to the women the correct way to use these devices. For this particular lavage brush, it has this button that is usually used to release about 5 ml of sterile water that is then splashed, so to speak, into the vagina while a woman is lying. And once they press the plants, as you can see on the video, it releases the fluid. And then once the brush, or rather the tip, once it comes back out, it sucks out the fluid and collects the cells with it. And that is what is taken to the lab for analysis. A study was done in one of our African countries in Gauteng, where they were looking at the use of a vaginal tampon. As you're aware, we're in a low middle income society, most of sub-Saharan Africa. And so sometimes these brushes are not available to us. So the usual tampons were used in a particular cohort where they assessed the women and whether the first collected tampon samples were as sensitive as you would expect to have a brush. This particular study looked at about 2,000 women, and out of that, it showed that for the samples that were collected through a tampon and the samples that were collected through a regular brush, that the sensitivity and high negative predictive value was still normal, or rather they were at par, and that the self-collected sample was, with a tampon, was still acceptable for use. Now, what you have to understand is, as much as you have all these methods or collection methods, not really have been put through a good trial, a randomized controlled trial with several participants so that it can be generalized to the entire population. However, from the small population studies that have been done, that's how this particular collection devices have been allowed to be used in population. So currently there are several studies that are looking at other methods less invasive for women. As you know, for the cell sampling, as much as you have to insert something into the vagina, even if it's the privacy of your home, of course, it would be good if you don't have to insert anything at all. So urine has been analyzed, and the efficacy is still under investigation. It still uses the regular PCR that the other tests use. And it has, for a few of the small studies that have been done, it shows that it has a sensitivity for detection of high-risk HPV of about 77% and specificity of 88%. So there is hope for use of urine. Menstrual blood, as controversial as that sounds, has been tested, and it has been described to be a very convenient approach for cervical cancer screening, particularly for premenopausal women, of course. But we still need several studies, large randomized trials that can confirm its efficacy, sensitivity, specificity, and proficiency. So all these tests, cell sampling, they can also be subjected to rapid result HPV tests, such as the expert HPV or KNH-UoN. And the reason for this is these are short running tests and can be more, one sample can be run at a go, not necessarily you have to load like 80 cartridges at a time. So, and for those places where you need to do screen and treat with lots to follow up, this kind of testing is available for these women with this kind of technology. However, we wonder, as much as we are having women collecting these samples by themselves, is it as efficient as if a physician collecting them? And several studies have answered this question. I specifically picked this one that was done by Dr. Jen Namuga at Moi University, one of the former gynecological fellows. And she looked at the accuracy of a self-collected cervical vaginal swab in detecting the high-risk HPV using the expert assay testing among women in Western Kenya. So the main objective was to determine the ability of these women to collect the samples themselves to be able to screen for high-risk HPV. So a cohort of women was subjected to self-collection, after which the clinician also collected a sample and went ahead doing visual inspection with acetic acid, but that's a whole other analysis, and patients were managed according to those via results. Now, when it came to the results of these two cohorts, it was found that for those who collected the samples by themselves, they had a HPV negative of 53%, while positivity was at 47%. When it came to the clinician collected samples, the HPV negative test was 63% and the positive were at 36%. So when this was this underwent a statistical analysis, it was found that there was an agreement between the clinician collected and the self-collected samples found in this almost 300 women. And so from a study from our very own Moi University, this has shown that it is very possible and it can be done. So we asked, which women specifically can do a HPV sampling? Is it all the women who come into the clinic, any woman who come encounter with? So there are some specific guidelines that we follow. Of course, this test should be available at patient request. And should the patient feel uncomfortable about having a speculum exam, sometimes the patient is just uncomfortable with the gender of the provider. They come, they see a man, they're like, I do not want to be screened by a man. So you should not miss an opportunity to have these women screened. Should the patient not have ready access to a clinician in case of distance barriers, these tests have been very good, particularly in the COVID pandemic. This HPV cell sampling became very, very common, especially in Western countries, where it was very easy to just mail the test to the women and then mail it back. And so that is one of the ways that it really helps during the pandemic. In our situation, we have distance barriers, particularly where a woman lives so far away from the health center. If we can find a way to get the samples delivered to the woman, and then they have a central area where they're collected and delivered to the hospital, this is one of the excellent ways to increase testing. Sometimes a woman will just decide, I'm not uncomfortable with speculum, but I prefer to just do a self-test. And because you're governed by the rules of ethics and patient autonomy is priority, we have to respect their wishes. Now, another group of women who will benefit from this is whenever we are having outreach or community awareness screening camps, we can do door-to-door tests. When we're going talking to women, wherever they are, we're meeting them at the village where they're at. You can go with this test, give the women, let them have go to the bathroom, take a sample, and they give them back to you. For some, in some situations, you can use mobile vans where you use even community health volunteers or community health workers. They distribute the test, then they bring it back to the mobile van, and the van transports the samples to the hospital. And I saw this quite a lot in South Africa with the Pink Drive initiative. And of course, you've mentioned mailed tests. And so if we have women who can be sampled, of course, we have women who should not do the self-sampling. And the top of the list is pregnant women. And this is for obvious reasons. When it comes to cervical cancer screening for pregnant women, there are specific guidelines, which I will not get into for this particular talk because it's outside my scope. When we're doing HPV testing for women under the age of 25, or rather for women at the age of 25, we cannot do HPV testing. It's recommended now for this one. You can't do the pap smears because the rate of positivity and clearance of the virus is very high. So you might lead to excessive treatment, and yet they can easily clear the virus by themselves. For women who have any symptoms that could be suggestive of cervical cancer, they're bleeding, they're having a lot of pain, they're having a lot of discharge, you should just examine the cervix as a healthcare provider. Do not let them do self-sampling because it could be a missed opportunity. And for these women who have overt cancer, they might likely end up being HPV negative. And so you might tell them they're negative, they go away, and then you've lost an opportunity there. For women who have had a hysterectomy, particularly due to past pre-invasive cancer disease or have had cancers, they've also have to have a gynecological exam where the vaginal vault or the cervix is examined by a healthcare provider, and it's not recommended for them to just do self-sampling for risk of missing out on disease. So of course, nothing comes without a few challenges here and there. And the kind of challenges that we have experienced with HPV testing are the same questions that arise when you're talking about pap smears. When you're advising a woman to come for pap smear, we tell them, don't come when you're having your menses, don't have sex for 48 hours before that, and don't use a lot of lubricants or spermicides and things like that. So how does this translate to HPV DNA testing? Several studies have looked at this particular confounders, and it has been found that whether the woman is having her menses, as much as it might be uncomfortable to the provider and to the woman, it does not have much of an effect in terms of the sample similarity, and you can still do testing. I mean, we are looking at menstrual blood as a source of cervical cancer testing. So menses should not keep you from screening a woman. Sometimes when you're doing this, using gel lubricants, and now this is away from self-test, some clinicians will be like, I'm not going to put a lubricant on the speculum, I'm just going to go in dry because it's going to affect the sample. No, it will not. The spermicide, the semen, any intravaginal medication, they have no adverse effect. And so in case you have these women, they're bleeding, maybe you've put a bit too much of the lubricant, or they've just had intercourse and they have a lot of semen in their vaginas, just take a cotton swab, clean out the discharge or the fluid, whatever is there, and collect your sample. At least this will make sure that every woman at every opportunity is screened and the validity of the test is not compromised. I'm running a bit out of time, but I'm done. So the main benefit of this self-collection is that it is increasing screening uptake. A randomized trial in the US was looking at uptake between those who had access to self-sampling versus those who had the usual care where you're being called to be reminded about your pap smear or your HPV test and you go to hospital. And it was found that those who had access to self-sampling had higher rates of screening uptake of about 26% compared to 17%. And this was a very small study, but still, it showed a big difference. And that means with self-sampling, you're actually tilting the balance into the favor of eradicating cervical cancer, which is hopefully one of our goals for 2030, or in this lifetime, hopefully. And of course, apart from this increased screening uptake, you see these women are going to be very comfortable. They feel safe. We're empowering them. And if they know that they can come to hospital, not have to undergo any invasive tests, you will see that most of them will actually come in to have the test. And they will go and tell their friends and encourage others to also get screened. So please join me in the fight to eliminate cervical cancer. Let's encourage our women to get screened, and most importantly, let's get our girls vaccinated against the HPV DNA. Thank you very much.
Thank you so much, Dr. Anisa Mburu, for your excellent presentation. I continue encouraging our attendees to send their question in the chat box. So we are going to welcome our last speaker for the evening, Dr. Doris Ndenya Mbithi. Doris is a holder of Bachelor of Medicine and Bachelor of Surgery. She has a Master of Medicine in Reproductive Health from Moore University. She has a 5-year work experience and currently working in McWayne County as obstetrician gynecologist. She is passionate about women health. Dr. Doris, can you talk to us about new technologies in cervical cancer elimination?
Good evening, everyone. It's my hope that I'm audible. Thank you very much, Professor Nelly Mugo, for the great presentation, and Dr. Anissa for the great presentations. Yeah, it's important to note that we really need to do a lot if we are going to eliminate cervical cancer as a public health problem, as WHO has stipulated. So of note, just to introduce my presentation is that Dr. Nelly, Professor Nelly pointed out that 30%, only 30% of the women who screen positive for precancer lesions receive treatment. And that's a very a small proportion of women. And I'm sure in some counties you may find that that figure is even lower than that. So for us to get to the WHO recommended 90% women receiving treatment, we really need to embrace technology and embrace the methods or techniques that are going to help us increase access to treatment of precancer lesions. So I'm going to discuss thermoablation. So yeah, so thermoablation is an ablative treatment for precancer lesions. It's also called coagulation or thermocoagulation, and it uses reusable metallic probes that electrically heated to about 100 degrees centigrade. So what that probe leads to is that there's destruction of the epithelium and the underlying stroma of the transformation zone. As we all know that most of the, actually almost all cervical cancer develops from the transformation zone, especially the area next to the scamocolumnar junction. So the women who need thermoablation are women who test positive for visual inspection with acetic acid, or have histologically confirmed CIN2 or 3, or women who have been screened with a high-risk HPV positive for high-risk HPV, and after VIA they have a positive VIA. So, but not all these women are going to benefit from thermoablation. So that is why there is an eligibility criteria to determine of the women who test positive for precancer lesions who can benefit from thermoablation. So for you to determine eligibility, you need to assess using either a colposcopy if it is available, or using what we are mostly using in the public facilities, which is the visual inspection with acetic acid. So most of these women will either be referred, or they'll just come for the usual routine screening, and then they'll be found to have positive lesions. So those who are eligible for thermoablation are women who have lesions that are completely visible, because you're applying the probe on the lesion, and your intention is to destroy all those cells that have changed the color, which are now precancerous. So you really need to be able to completely identify the lesion so that you're able to put the probe on the entire lesion, and then you're able to destroy the cells. So, and then the lesion should not extend into the cervical canal, because you're not going to be able to know the entire extent of the lesion, so you cannot be able to place the probe and destroy all the cells that have precancerous. The patient should not have polyps or cervicitis, because when you put a probe on a polyp, then that will interfere with the effectiveness of thermoablation, because you're not going to be able to deliver the heat where it is needed. Then the lesion should also not should be less than 75% of the cervix. So a bit about the procedure. So there's the usual, I may not go into every detail, every step of the procedure, but there's the usual patient preparation, where you have to talk to the woman, talk to them about thermoablation, talk to them about what side effects they expect from it, whether they'll feel pain or no pain. You discuss with them basically what it is and what it is intended to achieve. Then, of course, you have to have to put a speculum and identify the lesion through the either colposcopy or visual inspection with acetic acid. Then, before you go ahead, you need to make sure that the equipment is working. And the good thing with thermoablation is that the machines that we have in the county facilities, we have the Liga machine, as shown there, and the YSAP machine. So these are the thermoablation equipments that we have in the counties. So the good thing about these equipments is that you only need to switch it on And then you can check whether the battery has enough power or not. The machine is going to have an indication whether the battery is ready for use or not. And if it is low battery, then you are able to charge it before the procedure can be started. But these are things that you ideally need to have checked before you put the patient in the position for thermoablation. So then the next thing is that you need to place the probe on the lesion. And just a slight difference with this machine is that with the Liga machine, it will hit. You usually put it in the cervix, on the cervix, and then it will hit. You press the hit button while it is on the cervix, and then it is able to ablate. But the WISE-UP machine has to be preheated before you place it on the cervix. That is why it has a protective slider to protect the vaginal walls as you insert it. So, but the good thing is that they're automated, so there's no much thinking about how you're going to heat it or not preheat it. The instructions are usually very clear. Then one good thing about the thermoablation is that it takes about 20 to 30 seconds for you to be able to complete the procedure. And this is a big advantage as compared to cryotherapy, which used to take almost 11 minutes to do the ablation. Then the timings are already set, so you don't need to look at the wall clock to decide how long you're going to stay with the probe on the lesion. So that it makes it advantageous. And then you may need to do multiple applications, especially if you notice that you have not covered the lesion fully. You can move the probe and do ablation on that lesion until you're sure you've completely covered the entire lesion. So pre and post thermoablation, these are just images showing a cervix before thermoablation on the left side, then a cervix after thermoablation, and then after 1 month, when you examine the cervix, that is how it will usually appear. So the women need to know about post-treatment instructions, because it's very important. Because if they don't adhere to the instructions, we may end up with complications like bleeding and also infections. So they need to learn that they need to avoid intercourse or inserting anything into the vagina for about 4 weeks. Then if abstinence is not possible, then the patient needs to know that they need to use condoms to avoid infections. Then usually what is happening according to the guidelines is that the follow-up is usually after 1 year, where you need to rescreen the patient. But what happens in the counties is that the patient comes back after a month just to be checked on whether she has developed any of the complications. Then there's some health workers will schedule the patient again for 6 months and then after 1 year. So women who test positive after prior thermoablation or cryotherapy, is recommended that they undergo a lip procedure. Then side effects of thermoablation. So the normal side effects that the women should expect is mild low abdominal pains for about a day to 2 days, then watery vaginal discharge that lasts for about 4 to 6 weeks, spotting that lasts about 1 to 2 weeks. Very important for the women to know this, so that when they get these side effects, they are not alarmed. But then there are danger signs also that can develop. If the woman has fever, they need to come back to the facility as soon as possible, or they have severe low abdominal pains, especially if accompanied by fever, heavy bleeding with clots, and a vaginal discharge with a foul smell or unpleasant smell. Then that could imply that there's an infection that needs to be taken care of. So the women need to understand this before the procedure, and after the procedure, you need to tell them that. That is the things to watch out for. So this is just a comparison between thermoablation and cryotherapy. As you all know that we have 2 ablative procedures, the thermoablation and the cryotherapy. Cryotherapy was introduced earlier and is still being done in facilities. So thermoablation has very simple equipment. It's just a gadget that you can just hold with one hand. Then it's portable, and this makes it a plus for mobile clinics, especially for camps. When you go for screening camps, it makes it easy to have to offer treatment in such camps, because the equipment is easy to carry around. Then the shorter treatment time, about 20 to 30 seconds, makes it acceptable to most healthcare providers when they compare it to the cryotherapy. And then it's easy to perform. The machine is timed, and the healthcare workers really don't need to do much about it. They just need to identify the lesion, identify whether the patient is eligible for it, and use the equipment. It's very easy to use, and it is easy to train other healthcare workers on the job, as compared to cryotherapy, because cryotherapy now needs freezing gas. And with equipment that need gases, at times gases run out, and you have to go through the procurement process. And during that time, when there's no gas, you're missing, there's a lot of missed opportunities, because patients will be seen and they'll not be able to receive the treatment, and they may not come back for the treatment if they don't get it at that time. So it is not a very promising one. Then it takes longer, because you have to freeze for 3 minutes, thaw, then freeze again. So it takes a long time, and then you really have to time, and you have to look at the clock and see if the time is it's already 3 minutes or so. Then the gas containers are bulky, and this makes it difficult for you to transport them, especially when you're having mobile clinics or screening camps. It makes it difficult to have this equipment going on to those places. Then the gases may not be readily available, and that makes patients miss treatment. Then also frequent refilling of freezing gases can be costly. And when you look at the many competing priorities we have in the counties, this may not be considered like an urgent thing that needs to be sorted out. So it may take time, and the patients will be missing on treatment. So this is just to tell you that when you look at most of our screening rooms, they are really congested, because you find that that room has the other things, the other procedures that are being performed there. So you find that when you look at this picture, this is one of the screening rooms in the county hospitals. So you find it's congested. When you put the machine there, it is difficult to perform a procedure, and this may actually put people off. So, but with the thermal ablation devices, these ones you just use, you clean it, you disinfect it, and then you can put it in a box and you can put it in a drawer. So it makes it easier for use, and also for the space that we have, and also makes it easier to offer services to many women, because if you are doing it for 20 seconds, you are going to attend to more women than if you are doing a cryotherapy for such patients. So it's a very promising intervention that will help us at least to move the proportions of women who screen positive treatment from 30% to the 90% that is recommended by the World Health Organization. That is the target you should be working with. So for us to get there, we really need to embrace these technologies, and then you need to be able to utilize them and make sure that we have the gadgets available and functioning. Thank you.
Okay, thank you very much, Dr. Doris, for your very good presentation. So we will start now our question and answer time. And I want to ask, several people have asked questions in the chat box. So I will ask on their behalf, and I will welcome our speakers to answer as appropriate. We will be doing 5 questions at a go. The first question, I guess, is to Professor Nelly. Somebody asked, anonymous attendee asked, can women older than 14 years be given HPV vaccination? That is one. Somebody called Pamela asked, what is the issue with implementation of cervical cancer elimination plan in Kenya? Why are we doing poorly? Dr. Guer is asking, what is the Ministry of Health recommendation concerning the site of HPV vaccination? Is it in schools or child welfare clinics? An anonymous person is asking, after hysterectomy, is it necessary to continue doing cervical cancer screening using HPV DNA testing? And finally, this is specifically to Professor Nelly. Why is it that women living with HIV have a higher prevalence of cervical cancer? So let's answer those before we give people opportunity to ask questions directly.
Okay, first of all, thank you so much for your keen attention and for the questions. So one, women older than 14 years, yes, can be vaccinated. So as I mentioned, where they have, there was a shortage of vaccine for a while, but in countries like Australia, their vaccine programs offer vaccination from age 9 to 26 years. Now, we get our vaccines from Gavi, so they are donated, and then the country pays for distribution. So the guidelines now are up to 9 to 15 years. But as I mentioned in the KNH study, we enrolled girls up to the age of 20 years and gave them a single dose. There are studies which have evaluated vaccination for women up to the age of 40 years. What the difference is that the effectiveness is not as high because this is a protection. It's a prophylactic vaccine. It's not a treatment vaccine. And it works best if the individual hasn't had prior exposure. That's why we lean more to pre-sexual. But even when people have been sexually active, it doesn't mean that they have been exposed to all the high-risk types. And even if they've been exposed to one, they'll be protected from the other. But on a programmatic level, it's what's the best return for investment for government services. But as an individual, you can purchase vaccine. But remember, the guidelines now say age more than 20 should take 2 doses, 0, 6, and less than 20, 1 or 2 doses. The question of the challenges in the elimination program in Kenya, I think is an essay. We don't have, I think, resources. You know, campaigns are expensive, I believe. I don't have all the answers. The people in program can probably answer that better. I know that we're having challenges implementing visual inspection with acetic acid. You go to a health facility, you have one nurse who's giving vaccine, for childhood vaccine, who's giving family planning, and it's the same nurse who will have to create time for BIA. Some clinics may not even have a coach and other supply issues that we need to overcome. But I think the biggest challenge, I call it political will and commitment towards women's health. So we need advocacy in this area. The Kenya MOH recommendation currently is still on 2 doses, and countries are slowly beginning to adapt 1 dose, but Kenya hasn't reached there yet. I think I'll let, will it be Dr. Mburu or Dr. Mbidi who will answer the HPV screening question? But I can respond to the question on why are women living with HIV having higher risk for cervical cancer? So we say that many women, majority when you become sexually active, actually get exposed to HPV vaccine. And they say, you know, in a lifetime, up by age of 50, 80% of women have had exposure, but most women clear the virus. So the problem is the persistence of virus. So women who are immune compromised with HIV infection are less able to clear the virus and more often have persistent virus and faster progression from infection to pre-cancer to cancer. I think that covers the questions that I had, and I'll leave the HPV to my colleagues. Thank you. And thank you for those wonderful presentations that you both made.
Anisa Mburu or Mbidi for the question on hysterectomy.
I can take it. It's Anisa here. So the question is, after patient has had TAH, should they continue doing HPV testing? Did I get that right?
Yes, that is right.
All right. So 2 things. Number 1, what was the indication for the TAH? All right. Was it cancer related or was it related to a malignancy? So you find a lot of women tend to have hysterectomies because of fibroids, and a few will have now because of malignant indications. Now, what you have to understand about the human papillomavirus is that it's a sexually transmitted infection. Therefore, it not only affects the cervix, but it comes in contact with the vagina and the vulva. So whether a woman has a cervix or not, they still need to continue testing and having screening for cervical cancer. In this point, it will be the vault cancer or vaginal cancer, or even vulval cancer. We have seen some women, unfortunately, who have been treated for cervical cancer
completely recovered, but then they later develop vaginal or vulval cancer. And these are the type who, there's something called the HPV field effect, meaning that it can work in all these epithelial tissues of the vagina, the vulva, and the cervix to cause cancerous or malignant changes. So again, depends on the indication, but still these women have to be screened. Now, for those who have especially undergone radiotherapy or gone through some kind of intervention, definitely it would be good they're seen by gynecologists or gynecologists and they're screened by them. Thank you.
Okay. Dismas Ongore, your hand is up, so we give you opportunity to ask your question.
Yes, thank you very much, Philip, for that excellent moderation. And thank you very much, Nelly, Anissa, and Doris for those excellent presentations. I was thrilled to be a part of all of this. I am a public health physician. I'm also a professor of public health with a lot of interest in cervical cancer. Just a comment. I think the major challenges, some of the major challenges you are facing with cervical cancer elimination is uptake of vaccines and uptake of screening. Our vaccination is at 15%, uptake of screening is at 16%. So when Anissa was talking about self-sampling techniques, I was very, very happy that these technologies are available and they are within our reach. My main concern is how do we go to scale? Is there a reason, is there room for looking for mass screening with these available technologies? Because I think, in my view, that these self-sampling techniques may just solve our problems of uptake, given the problems with the current pap smear and so on that are very invasive, culturally not sensitive. So I would be very, very interested if there's somebody who has had experience of trying to go to scale. Why? What is the problem with going to scale? Like having this being routine tests in our health facilities. I know we have talked about their costs and so on. And then for Nelly, the vaccine hesitancy. I know the current recommendation for Kenya is the 2-dose, and this 2-dose is health facility based, which I think is also a challenge. Now, you've mentioned that the SAGE recommendation by WHO has now recommended that we have a single dose. I still wonder where the challenge is. Why have we still not gone to the single dose given the SAGE recommendation? And also, why can't we explore other strategies rather than just being facility-based? Why can't we try a mixed base? And possibly we will address the issue of uptake of both vaccines and screening. And then there was the urine sample test for HPV, which looks very, very promising. Maybe this is something else that should be explored. But otherwise, I am a very excited person that given what we have, and with just more effort on our side, more awareness, more social mobilization, we may just approach that elimination. Thank you.
Thank you so much, Dismas. Any other person? I don't see any hand up. Any other person who wants to ask directly? Keep it short and concise. No one. So I will give the opportunity, I think, Anissa and Professor Nelly to answer those questions from Dismas.
I think for my part, Dismas, thank you so much for your comments. Most of them were comments which I agree with. I don't think there was a question in them. Thank you.
Okay, so we will take the next 5 questions. And Akin is asking, where are these self-collecting testing kits available in the country? One anonymous person is saying majority of our women stay in the rural areas where they are underserved, both in terms of healthcare workers and availability of facilities. Unless we decide on innovative ways to reach these women and the urban poor, the WHO targets of 90-70-90 will still remain mirage. So I think she needed some comment from you people. The third one is from John, and it is addressed directly to Anissa. Are the instruments for self-collection lubricated? Any report of discomfort or vaginal injuries? How available are HPV testing services in Kenya? And how are they distributed? Hadija is asking, can HPV DNA testing be done in the first trimester? Let's go for those, and then we will have the last group of questions.
All right. Thank you very much, Dismas, for your comments. I really take them, a lot of them, into advisement and support what you're saying. And for those excellent questions, I hope I'll get all of them. So one of the issues was about these self-sampling kits. Are they available? It's a two-pronged answers. In most high-end facilities, yes, they're available. For the rural women, unfortunately, they're not that readily available, because you find that in private care facilities like Aga Khan, where I work, MP Shah, I think, and some other facilities, these testing devices are available. In Lancet, they also have the Evelyn brush. There are some screening drives that have been done using the CHI initiative, where they're doing HPV testing, and it's available in some select counties at a very low cost. I think maybe 150 to 250 shillings. I'm not very familiar with all of this, but it's only available in some counties like, I think, Nakuru, Kisii, Vihiga, and places like that. For any woman who wants to go and have this test, they can't show up in a private healthcare facility or Lancet, as I said, and even Metropolis. So when it comes to having this test available for everyone, that would be my dream. And I've been shouting from the rooftops, we need to get every woman screened. And it's the women in the villages who are coming down with cervical cancer, very late stages. And this, as I think Prof. Nelly mentioned this, if we have the government goodwill, where they are partnering with NGOs, partnering with social societies to set out the screening facilities, making them available and mostly affordable for our rural women, that will be a dream come true. And so the onus is on us as healthcare workers to impress upon our government workers, if we can get this key stakeholders to provide these brushes or to sponsor us, because at the end of the day, money is what has been a main challenge, and that's why we've not been able to avail these facilities. I know in MTRH and when university, and Dr. Tony can correct me if I'm wrong, but there are testing that is being done for HPV and studies, various studies. And so that has been one way to increase uptake, especially in Western Kenya. So the opportunities are there. We just need to channel them, and to channel them on a large scale. And yes, we need to stop talking about it and actually doing something about it. Now, yes, urine can be a point of care testing, but as I said, there are still some investigations that need to be done before it is rolled out. And the other question was about lubrication of the collection samples. Well, understand, most of these devices are very small. They're even smaller than a finger, an index finger, for example. And so they have very ease of access or entry into the vagina, which is already for most women self-lubricated. So these instruments are not lubricated. They have very easy penetration, so to speak. And so far from the women who've gone through it, no one has reported any injury or any discomfort. In fact, the women come out smiling. In fact, they go in scared, but they come out smiling and they feel they were in control. So they could take it slow, they could take it easily, and no one has ever reported an injury, and it's very comfortable to them. And I think there's a question I've missed, Dr. Tonoi.
Oh, yeah, the next question was, can HPV DNA testing be done in the first trimester of pregnancy?
Oh, yes. This is a very good question, because for pregnant women, these are a special group, and we do not recommend routine cervical cancer screening by any method on these women. And the reason for this is this. Yes, you screen a woman in the first trimester, she's HPV positive. What are you going to do? You can't leave her, you can't do surgery on her, you can't do much. Because most of the time when a woman is pregnant, they'll want the pregnancy, unless it's a very rare situation where they don't want it. But the issue has been, there's also a lot of pregnancy changes that occur in the cervix, and there's nothing much that you can do about it. So for women, as soon as they discover they're pregnant, let them come in after 6 weeks postpartum, then you screen them. And that goes for any method, via pap smears, all of them. Thank you.
Okay, so we are going to have the next batch of questions, and I think it will be our last. So Caroline Koske is asking, is the nanovalent HPV vaccine available in Kenya? Purity is saying, what is the price of HPV self-tests? And Caroline is also asking, can one get Gardasil as a booster after taking Cervarix? How many doses? Waweru is asking, why should both sexes be vaccinated? Is it just a question of cost? Lynette is asking, how do we treat HPV in men? And one other question is, I think a very important question is from Victorio Torres. He's asking, is NHIF covering the self-test for HPV? And if it is not, what can be done so that it can get covered? I think it is costly for women and also for many health facilities. I think there was one other question about to Doris. Is it time to switch from cryotherapy to thermal ablation as a country? Let's answer those, our speakers.
So I think I can start with the issue of what we call gender neutral vaccination. That's a vaccination of men or boys. I personally had my sons vaccinated. On a public health level, the prioritization is vaccination for girls. If you remember the chart, the bulk of disease for HPV-related disease is cervical cancer. And what actually are the biggest burden? But you know, what's are nasty, not nice to have, but not life-threatening. A few may turn cancerous. Men sometimes get urethral warts, which is also nasty. And there are other diseases that men can get from HPV, like some of the oropharyngeal tumors and papillomas. So where resources are adequate, and on an individual level, I would say get your boys on an individual level vaccinated. On a public health program, that may take a little bit longer. It's also been shown that if you have high coverage for the girls, you can achieve what you call herd immunity in the boys. I think my question was basically that on the vaccine.
And Doris, tell us about, is it time to switch from cryotherapy to thermal ablation as a country?
Yes, I would. My answer would be yes to that question, because studies that have been shown comparing thermoablation and cryotherapy have shown more or less similar cure rates. with rates of more than 90%. So looking at the logistics and the equipment and the convenience of using thermoablation, and the fact that actually looking at our data, like I was just reviewing our data from the county, is that actually most of the patients who received treatment for positive lesions received thermoablation. And that does not mean that we actually have the cryotherapy machines, but they were not used as much as the thermoablation machines, because they have been shown to, the thermoablation machines have been shown to be more acceptable to the healthcare workers, more convenient, and they are easier. You can provide the service to majority of the women within a short duration of time. And the equipments are also easy to maintain because you just need to charge and you can use it. You can charge it and you can even carry it and go and use it elsewhere. So I think if you're going to really increase the number of women who test positive and receive treatment, then we need to use thermoablation because it will give us higher numbers of treatment. Thank you.
Okay, and the question associated with that is, how do you clean thermal ablation equipment between clients?
Yeah, so what happens is that once you have used the thermoablation equipment, then you need to clean the probe. Usually it's the probe that needs to be cleaned. For the rest of the equipment, the part that contains the battery, you just need to clean. You can clean with a sanitizer or a spirit, surgical spirit. But for the probe, you need to clean it with clean water. They usually just clean, I would say, the MVA kits. You clean it, make sure that there is no debris, no tissue on the probe, and then you can put it in Sidex solution for about 12 to 15 minutes. And then you can rinse it off and you're ready to use.
Okay.
And then also there are times when you have used it and maybe you have many clients who are following each other. There's a way you can just like is it the one of the machines, you can just do like you're doing a full treatment cycle without putting it on the patient. So you just press it on, it goes through a full heating cycle, like you have, you're treating a patient, then that will be able to sterilize it, so long as it doesn't have tissues on the probe.
Thank you very much. So Dr. Anisa, is self-collected HPV DNA testing covered by NHIF? And how available is the service of HPV DNA test? Oh, you had answered that, sorry.
That's okay. So yes, for the NHIF comprehensive, it has been covering for my patients. For the other NHIF, sometimes they need a medical report or something like that. So you have to really convince them. And it is, I think, for anyone who has contacts with NHIF, we need to talk to them, because whenever we tell them it's for cervical cancer screening, now they understand and then they go ahead and approve the tests. In terms of costs, it ranges depending on the facility where you go. As I said, depending on where you go, there's some places where it's free of charge because it's under a clinical trial. Others, it's under the government initiative. It can be 150 to 250. Other places, it can be 3,000, others 8,000. So the spectrum of cost really, really varies. And that's why we really need to talk to these facilities, talk to the labs, and see if we can get a national movement to cost reduction of this particular life-saving tests. I think there was a question about how do we treat men with HPV? And the answer is that we do not. Because the same way we do not treat women with HPV, for the men, we do not treat them. There is no treatment for HPV that is currently approved. And for the men, we don't even test them. Unless they have some symptoms of penile cancer or anal cancer, then we can do biopsies and other kind of tests for them. And for the women who do test for HPV, then we do a diagnostic test, which is mostly a colposcopy with or without a biopsy, depending on what is happening to that particular patient. And remember, the reason we're retesting these women is because you can test a woman, she turns positive, she goes through the colposcopy treatment and everything. In 5-10 years, it can recur. She can get reinfected and still develop cervical cancer. That's why it's important to follow up these women and to keep screening them so that at least they have 2 to 3 screening tests in their lifetime. Thank you.
Okay, we promised that we were going to end our presentation at 8:30. It's now 8:33, but we started, I think, 5 minutes late. So I will take 2 more questions and then we finish. So I think this has been answered. Boru is saying, great presentation. What is the chance of reinfection and subsequent development of cervical cancer in women who have been treated? I think Anissa just answered that. One anonymous attendee is asking, what is the role of Papillocare gel in the treatment of premalignant cervical lesion? Anyone who wants to answer that?
I could give it a shot. So Papillocare has come with a lot of, it's the shiny new toy in terms of HPV testing and cervical cancer. Some studies have said that it can actually help patients with low-grade disease, meaning they're just having cytopathic changes from the HPV to recover faster and slow down the rate of development of high-grade disease or even cervical cancer. I think there still needs to be more studies for this particular drug before we openly market it. And as it stands in terms of cost, it's very exorbitant from what I've heard, but I have no experience in that particular drug, just what I've read from papers. As of now, I'd say let's just wait for a few more trials before we can advertise it more.
Okay, in the spirit of trying to answer all the questions from people who attended, I will ask the last 2 questions. Professor Nelly, is the government willing to partner with social enterprises to create awareness and distribute vaccines, especially in isolated regions? And then somebody who is working in Kisii County is saying, I'm encountering 35-year-old women with stage 4 cervical cancer. It is also common in that area to find 13-year-old women giving birth. Which is the appropriate age to start screening in this situation? Those will be our last questions, and then we finish our presentation. Thank you very much.
I also want to really thank you, Dr. Tonui, and thank my co-presenters and the audience for their attentiveness to this topic. I'd like to start by saying we need a lot of advocacy efforts in reproductive health. You know, I work for the Kenya Medical Research Institute, and the Division of Family Health is best placed to be approached about supporting advocacy. But I've never heard of the ministry declining support in advocacy because we have vaccines expiring in health facilities, HPV vaccine. So I would propose to the person interested, kindly approach the division. I think Kenya has one of the best vaccine units, really successful. They know what needs to be done, and with the resources in place, they can do wonders. The launch of the vaccine itself was excellent. So I would say approach the division. I think the second question, I'd like to say there's no 13-year-old girl. Let's just clarify that. And remember that anybody who's having sex with a girl below the age of 16, it's assault. So that girl has been assaulted. It's a problem. If you have a population where 13-year-old little children are pregnant. So the other question of when to start screening, the guidelines for Kenya is 25. HIV-infected people may be 21. You know, cultural perspectives about sexuality when initiate, the DHS shows that age of sexual coitage in Kenya is around 17 and 18. Thank you. Thank you very much for the audience and the questions.
Thank you very much. I wonder if there are representatives from Kenyatta National Hospital, University of Nairobi, who are participating in the organization of this presentation, and if they want to make a comment.
This is Nelson from KNH Research.
Yes, Nas.
Mine is just to thank all of you for coming together and giving us all your input regarding this topic, especially as you're wrapping up the month of January, which is the cervical awareness month. Mine is just to thank you and to congratulate you on the good work you have done.
Thank you so much. So good evening, everyone. It was upward of 600 people who attended, so it was really well attended. Thank you very much. Have a good evening. Enjoy your time. Bye-bye.
Thank you so much.
Bye. Bye. Thank you.